Afternoon. I'm Joanne Conroy, and we're here with our Facebook Live with my guest, Dean Duane Compton, today. I know that many of you are logging on right now, so we'll just give a few minutes for all of your colleagues to get on the Facebook Live before we get started. Now, many of you know that you can submit questions to us through the Facebook page, and somebody will take those questions and will hand them to me. So please feel free to provide questions or give me some topics that will actually make this interview more interesting and interactive for you. Again, welcome to Facebook Live from our new studio here, right by Craven's on the third floor of Dartmouth-Hitchcock Medical Center. Can I get started? Great. So again, Joanne Conroy, and I know a lot of you are logging on to our Facebook Live, and I have Duane Compton, who's Dean of Geisel School of Medicine here. So Duane has been my really important partner here for the first 11 months of my tenure. And I was looking at your bio, Duane. So you trained at Oklahoma and then Texas. And I assume you got your PhD at Texas?
Texas, yeah.
So how did you get to New Hampshire?
It's a long story. So first of all, thank you for inviting me to come here. This is my first Facebook Live experience. So see how it goes if I have a future in Facebook. So my path took me, I was born and raised in the Midwest, and my path took me to the University of Oklahoma for undergraduate. And that was largely because I had family there. Also, I have a strong independent streak, so that was a way to get, at that time in my life, some distance between me and my parents.
Most kids go to California. Then, you went to Oklahoma.
Yeah, well, I do have an independent streak. And then graduated from there and went to graduate school at the University of Texas Health Science Center in Houston, where I was able to work at the MD Anderson Cancer Center.
Oh, wow.
So my PhD is in cancer genetics, and this is something that was very, very active at the time. This was before the genome was sequenced, so it was quite a different field than it is now. And after graduating there, I then went to do postdoctoral training at Johns Hopkins School of Medicine in Baltimore. And at the conclusion of that, so that work was mostly basic cell biology. And then at the conclusion of that, I started looking for academic positions, for faculty positions. And Dartmouth rose to the top as one of those places that I wanted to further my career. So this became my first independent academic position. I moved here in July of 1993, so almost exactly 25 years ago now. And have been teaching and running a research laboratory ever since then.
So what attracted to you about coming to Dartmouth College to continue career? People, lab, the area, the culture of the community?
Yeah, it was very much driven by the community and the way that people everyone seemed to get together to recruit faculty. Everyone got together, regardless of which department, regardless of which discipline they're in. Everyone kind of pitched in, and that community spirit was really, really strong. So that was a big attractor. I have to say, moving to this community, it's a very small community. That really wasn't part of my thinking.
Yeah.
Frankly, it was really a professional decision at that time about the position.
Yeah, you didn't even have Amazon back then.
Yeah, right. And no cell phones or but I have to say, since I've just grown to love the area, and it is remarkable to me that we can sort of do the kind of science at the caliber we can do, interact with the physicians and the students and everything in the way that we do, and also live in this community, this setting where you can go skiing in the winter and skating, and you can go hiking in the summer. It's a remarkable combination that isn't matched pretty much anywhere else.
So talk about the culture that attracted you here. So 25 years later, there are a lot of other stresses. Have we been able to maintain that culture that attracted you here?
Yeah, I think very much so. I think I see it now from the other side of the table when I'm now in a position of recruiting people to come to the institution. I see the community rally behind those recruitments, and it's very much still alive. Most recently, well, you helped me work to recruit the new director for the Cancer Center, and I think when we were recruiting him, he very much felt that draw from the community, from all corners. So I think it's still very much here. Yeah. It's a very collaborative atmosphere. There are very low barriers to collaboration, and I think that's a really important part of what makes this place its secret sauce, if you will.
Yeah. So the physical plant has changed in the medical school a lot over the last 25 years.
Yeah.
Was that actually, we hadn't moved yet, had we?
And yes, and the move happened in 1991.
Yeah.
So I came, I think within a few weeks after I arrived, they did the demolition on the old Mary Hitchcock Memorial Hospital building. Yeah.
Yeah.
And so I actually got to see that happen. I didn't really realize the long range implication of it when it happened, but yeah. So we've been building on both campuses, both locations ever since then.
Because look like there are a couple new research buildings there. Is the translational research building there.
Yep.
And then we've got the Williamson building here.
The Borwell building, the Rubin building has been expanded in that time. It's been a period of just multi decades worth of growth. Actually.
How big is the faculty now, do you think, compared the basic science faculty compared to when you came?
It's larger now. It's again, it's been multi decades of growth, and so we've been very fortunate to have certain grant programs that are federally funded that actually provide funds for faculty recruitment. So we've been able to build particular areas of faculty using that mechanism, and then that is in addition to our ongoing investment always in faculty recruitments.
I'm going to talk to you a little bit about your own research in a minute, but I want to remind people that if you've just joined, this is Facebook Live with Dean Duane Compton from Geisel School of Medicine. And if you have questions or want us to talk about separate topics, you can email us through Facebook, and those questions will be submitted and incorporated into our interview. So talk to me about your research, because of your background, you do a tremendous amount of biochemistry research in oncology. I mean, your research is how cells actually divide and become stable or unstable tumors, and how we can modify that with real implications in terms of how we treat patients. And I understand you had a merit award in 2014 from the NIH, which is nothing to sneeze at.
Yeah, that actually, that's a funding mechanism that gives 10 years of funding, which is really helpful because it allows me to think much more broadly about how the work evolves and where to go. So that's been really, really helpful to me. Yeah. The work that we do you can trace its origins back to my degrees, right? Yeah. And my training. So as a graduate student, I was doing cancer genetics. I was trying to understand and map the location of particular tumor suppressor genes. As a postdoctoral fellow, I did much more basic science on cell division, how cells divide. And as I started my own career, I sort of put both of those together, and I've been following that path ever since I've had my own group. And so the fundamental question that we're trying to understand is that we all inherit one copy of chromosomes from our mom and one from our dad. And as we grow and the cells divide, as we grow, the cells partition those chromosomes perfectly every time. So each cell in your body has
amazing.
Exactly the same number. It really is remarkable. But what we know is that most tumor cells actually do not have the proper number of chromosomes. So they're making mistakes in that process. And in fact, what we study is a phenomenon called chromosomal instability, which is they don't just make one mistake. They seem to have an inherent problem that they make mistakes every time they divide. So the tumors are constantly shuffling their chromosomes. That's a feature that's very unique to the tumor and not to your normal cells. And so what we're trying to do is figure out what's causing that and figure out how we can interrupt that in a way that affects the tumor cells only and not the normal cells.
Do you think, if you carry that thought forward, does the tumor change as it ages in
Yeah.
terms of its susceptibility to some of our interventions?
Really good question. As a matter of fact, yes. So you can actually look at different positions within the same tumor, and you can find different genetic makeups in,
Oh, wow.
in that. And people oftentimes look at tumors from an evolution point of view, much like species evolve
Right.
to take on different traits and characteristics. People view tumors in the same way. As they're
Mm-hmm.
growing and changing, they take on different characteristics.
Mm-hmm.
That instability that I talked about is very strongly associated with things like drug resistance and tumor recurrence after treatment.
Yeah.
And it's thought that ability to constantly change is giving the tumor the ability to circumvent the treatment.
To survive.
Yep, to survive.
Yeah.
Survival of the fittest, basically. And
Yeah.
those cells become highly successful at that.
And more difficult.
And
to
much more difficult.
manage.
Yeah.
So how do you balance research and what I'm going to talk to you about next, which is your other job, which is actually running the medical school, because you obviously have real passion about what you do.
Yeah. Balance. I don't know if balance is the word I would use. It's
None of us are really great at balance. Let's agree on that.
It's definitely a challenge. There's a lot to do on both my administrative role and my scientific role.
Mm-hmm.
I teach far less in the classroom than I used to.
Mm-hmm.
I miss that a little bit, but I definitely have had to pass up on that a little bit to do these other roles. I have to say, in the laboratory, I really have some outstanding students and postdocs who are really, in many respects, self-sufficient. I work with them every week, but they've really taken on a lot themselves. So I don't think I could do this without having them have some independence. So it's always a challenge. A lot of nights, a lot of early mornings for me. I'm an early riser, so a lot of early mornings, a lot of weekends.
Yeah, you're probably not alone in the labs early morning and weekends, because I think researchers, they end up letting the research determine when they're going to be there, often rather than their schedule they would like to have.
Right.
So you do have another job, which is dean of the medical school. Talk a little bit about the challenges that a dean faces now. I mean, it's very different than when I went to medical school. I very much appreciate that. So,
I think at the highest level, the role of the dean is to facilitate the work of the faculty and the students. Facilitating the education programs, facilitating the research programs, ensuring that everything is running and financially supported properly. So that's fundamentally the job, but within there is the challenge, and particularly in this current environment, it really is a challenge around how to resource all of those activities properly, financially resource things properly. So we spend an awful lot of time trying to ensure that we're applying our resources in the best place possible, so that we can ensure our mission.
So the resources really are faculty resources. Is that the most expensive resource?
It's faculty and staff, and it's facilities. Research programs.
How have facilities changed? I mean, I remember a big lecture hall where, half the kids didn't show up and half the kids were asleep, and there were 4 of us sitting in the front row taking notes. So, talk about.
Oh, you were one of the front row people.
I was one of the front row people because you had to stay awake.
Yeah. So much of our education and curriculum now is based on small groups and facilitated learning in small groups, where a lot of the students do most of the work and faculty are facilitating those discussions. Okay. But that means we've had to sort of change the way we physically structure how this happens. So far fewer big lecture hall sessions, far more small group sessions. So we've had to invest in building small rooms for all of those small groups.
Do they like their own room?
They're all concurrently happening. So, so we have to have rooms that support groups of 8 to 20 students, all happening concurrently. So that's 10 to 15 rooms.
Do they all kind of learn together? Just like the group of 8 or 10 stay together throughout
Yeah.
their first couple of years in
Yeah.
small groups.
Yep, oftentimes they do. They also work as small groups in the anatomy lab, so and we try and continue that group setting in other areas. Um, they learn an awful lot from each other. It's and this is part of our curriculum, which is not just to educate the students, but to create lifelong learners. And so a lot of the small group sessions are about facilitating the students to learn how to go find information when they need it, and then bring it back to help teach the other students.
So you have to teach faculty to facilitate differently than when they used to give lectures.
Yes.
So how difficult is that?
I think there's a generational aspect of that. I think, so first of all, from an information transfer, it's far more efficient to have a single large lecture room. And so it just has to be somewhat different. And then different faculty are more comfortable in a large group setting than a small group setting. They're very different, and some faculty are more comfortable in one setting versus the other.
Now, how are students different, do you think, now than they were 25 years ago?
I think for me, so first of all, we recruit some outstanding students. I'm just humbled, honestly. Every entering class is, to me, is equal or more impressive than the last entering class. It's remarkable to me, the accomplishments of these young people when they come in. I think for me, the difference is that many of our students wish not only to get a medical degree, but also have a way to apply that to address a social issue, or apply it to in an entrepreneurial way, or apply it in a science way. So it's more about combinations now than it is about the singular.
Interesting. So how is it different to train a student in a relatively rural area of the country? Because we are the most rural academic medical center in the country. That must offer incredible opportunities, but also some challenges for some of these students. Aside from there's no Grubhub, and there are 5 restaurants in town.
Yeah, well, I think students are pretty well informed when they come, so I don't think that the rural environment is a total shock to them. So because there's a lot of networking that goes on during the interview process, and so I think they're aware of that, so it's not a big shock.
They should be studying anyway.
Think for some of our students who move here from the West, the winter is a bit of a surprise. But the rural nature actually is, I think, it's an asset in many respects, because we have really interesting ways that our students can get into the community and have real meaningful impacts on the community. They staff some of the volunteer health systems around.
In White River, they staff both the, medical clinic over there.
And Mascoma Clinic and Good Neighbor Clinic, things like that. And then they also get to partake in things like providing basic health services for migrant workers that are in here during the summer months. So that's a real asset. It's also helps illustrate how they can use their medical training to improve the conditions of the local community. I'm not so sure that's as easy to do in a more a more urban environment. However, I have to say our curriculum, and we have several programs like the Urban Health Scholars, which are designed to take our students and put them in an urban environment as well as a rural environment.
Where do they go? They don't go to Manchester. They go somewhere else.
We have lots of places. So we have a relationship with California Pacific Medical Center in San Francisco. We have one in Orange County in Los Angeles. We have all over the country. We have different ways to the urban health scholars tend to go to Boston or New York. They went to New Orleans one year. We have lots of different ways to get our students the right combination of clinical exposures. Yes.
So do some of those institutions send their students to us for a rural experience?
Not that I'm aware of.
Oh, no. Interesting.
We should talk to them about that.
We should talk to them about that. Yeah, because there are probably a lot of things to be learned about families that live 4 miles down a dirt road and
Right.
don't always have reliable electricity
Right.
or clean enough water.
Right.
Um,
When I think about the rural setting, I think one of the biggest influences about health outcomes and health access is around transportation.
mhm.
In a rural setting, those individuals have to travel much further
Yeah.
and so their access to healthcare becomes limited by their ability to travel
Yeah.
and but it's very interesting to me because I think about that and I think the same burdens exist in an urban population. It's not the same challenge. It's not the distance, but in an urban environment, you have the same travel burden,
Right.
which
They have
is
to go down 5 flights of stairs because they don't have an elevator.
and if they rely on public transportation,
Yeah.
how often does it come? Do they have to make changes?
Yeah.
You know, what's the schedule? Does it take them an entire day to get there and then get back? And
Yeah.
I think transportation is a huge aspect of health system utilization and access and health outcomes that should be explored.
Yeah, that's a good point. We know that fewer than kind of 40% of the people that are at DHMC actually come from the Upper Valley. So
Yeah.
a lot of people come from really a long distance away, which affects not only how easy it is for them to access a specialist there, but the continuity of care. So.
And I know there are some philanthropic programs that we have that supply gas cards to people. So, try and take the travel burden away from them by providing the financial support to pay for gas and things like that. So, trying to bridge that gap.
What if, when you think about your interactions with the students, what has been a project or initiative that they've taken on that's really kind of surprised you or inspired you?
There's a particular program that a few students started a year ago, and it's called Beyond the Books.
Okay.
This was an inspiration of some of our students to bring to light the aspects of social justice into our curriculum, and so they ended up working in the local community to bring individuals to come talk to the other members of the class. So, for example, someone who had overcome a drug addiction problem, or someone who had been incarcerated, things of that nature, to try and destigmatize those people. They're still patients, they're still people, and we shouldn't allow that social challenge that they had faced at one time to influence the way the providers would want to see them. So that was a whole program set up by the students. It's really something now we're working hard to think about how to put as part of our required curriculum for all of our students. That was a small group that started that, and it's been so successful and impactful. We'd like to expand it to the whole class.
Yeah, that's fascinating. I just want to remind people that I'm here with Duane Compton, Dean Duane Compton, and on Facebook Live. And if you have some questions, please submit them to us through Facebook. And it says 20 minutes. I have a question about poverty.
Mhm.
So there are a number of medical schools that have courses on poverty. Have we ever thought about having anything like that here? I was impressed that poverty actually not only affects your access to care, but sometimes even can affect the judgment that you bring to your care setting, because when you're just trying to stretch a dollar 10 times further than it should be stretched, it overwhelms you.
Yeah.
So
we do that gets incorporated as part of our course called Patients and Populations. This is part of our curriculum that I think is distinctive for us as a medical school relative to other schools. We put a lot of time and effort into this, which is it's a course to help the students understand not just how to deliver care, but how to deliver it most effectively. So how do you analyze the system that you're working in? How do you make improvements to the system that you're in? So there's a segment in that course that does deal with poverty, and in so many cases, there must be an understanding that health outcomes and whatever the physician does in working with the patient is going to rely on what that patient does when they leave the office. And so we do talk to our students about how to gain enough information to understand how their treatment will have the best effect.
If the patient can afford the medications,
Right.
if they can take the medications,
Right.
if they have any concerns about them.
Right.
Yeah. Interesting. Yeah, I think it's a bigger and bigger factor
Yeah.
in compliance. And I'm not sure our challenges in getting accessible healthcare to people that are the most vulnerable in our society is actually solved just yet. So I think we'll struggle with it.
I think
for
we've got a long way to go.
Yeah. So I know you guys are starting the campaign. And there are a lot of really important initiatives. I know investing in the Cancer Center, investing in TDI, and investing in a lot of big bets in research. If you had $100 million and someone kind of wrote a check and said, Dean Compton, put this to the best use you can, what would you do?
I mean, we have priorities that I think that would make a huge difference in what we're doing. Mm-hmm. So a donation of that nature would go towards, student scholarship, which would start making it much more affordable for students to go to obtain our degree, which is, I think, the best in the country.
Right. And students have a lot of debt.
The students end up with a lot of debt. I think we have a really good endowment at the moment, so our students graduate with that. That's about average for most medical schools, so I feel good about that, but we could do lots better.
Yeah.
On the research side of things, a gift of that magnitude could transform something like the Cancer Center or something like the Dartmouth Institute for Health Policy and Clinical Practice. Those are really groups that take a very institutional point of view towards attacking a particular problem. And a gift of that size and magnitude could really transform our ability and the way in which the faculty could have success in treating either cancer or creating new, more effective health systems.
Yeah. Is the greatest return on investment in kind of bricks and mortar, or is it in people? Or
right now I would say most of it's in people. We use an awful lot of our philanthropic support going to support faculty through endowed professorships, to support programs, which usually means recruitment of staff or students or things like that. So it's an awful lot about people.
People are usually what drive kind of our breakthroughs as well as improving our culture. Great. We have a question from the audience. How does Geisel School of Medicine integrate the needs of rural populations into their program curriculum? So the needs of rural populations instead of the rural or poor patient, just the population.
Yeah, so we do this in two ways. One is formal in the curriculum, so we make sure that our students understand the needs of the patients, and a lot of our students are trained by from volunteers in the community who come in to work with the students. So that's a formal part of the curriculum. There's also what we call co-curricular activities, which are happening outside of the formal classroom curriculum. Those are activities that are things like staffing the Mascoma Clinic and the Good Neighbor Clinic and the migrant health workers. So there's lots of avenues for our students to interact directly with the local community and to provide basic healthcare needs for the community.
Now the students actually provide a lot of service here. The first 2 years often, not completely, but often are really acquisition of knowledge. And the second 2 years are really trying to learn about kind of judgment and the clinical aspect of the world that they're entering. How do the students feel about their experience here at Dartmouth-Hitchcock? And what are the things that we might be able to learn from them to kind of improve the environment? They are our future. Many of them become residents here, and many of them also returned here.
Yeah, I think that I would say for the students, it's going to be the same as for everyone along the professional spectrum. I think the way we could try and improve things is through better stress management. There's an enormous amount for them to take in and understand and learn and master in a short amount of time. And there's a lot of stress on the students. But that stress management, I think, goes all the way up the professional spectrum. So I could certainly use some advice on stress management. But I think, we hear about physician burnout all the time. I just think...
You think students are also subject to that, even though
Yeah.
we've really changed their experience, but it doesn't probably make it any less stressful
Yeah.
because they start thinking about their residency opportunities
Right.
probably really early on in their training.
Yeah. So it is all about trying to manage all of
Yeah.
that. It's just a huge amount of information that they need to master, and and then making decisions, life changing types of decisions. As you're going along that, it's just a very stressful period.
Yeah. And there's probably a shift in medical students where they start to appreciate that they're entering a profession. It's not school, it's a career.
Right.
I remember I was shocked when I couldn't wear flip-flops on the clinical wards. I was warned by my sister that that would not be acceptable. But I noticed the students actually, they do look very professional, and they kind of make that shift. Or are you guys coaching them?
Yeah, there's some coaching that goes on, of course. Well, of course. I mean, no, you're right. People are stepping into a professional environment and you're working with other people. So there's a lot of training that goes on in coaching with respect to your interpersonal skills and how you work with patients. Let me turn the tables and ask you a question.
Oh, because you saw we got the high.
I want to get one in before you. So you are approaching the 1-year anniversary for leadership at Dartmouth-Hitchcock. So I'd just like to ask you to reflect on that and what you've learned.
Yeah, well, thanks, Duane. So yes, it's been almost a year, and I actually was reviewing the notes that I took the first month I came as I was kind of doing my listening tour. And there were 3 things that were really important. Number 1, financial and operational stability. And I think that has been actually maintained and improved. So we've been able to reinvest in our employees and in the organization, which is great. The second was engagement. It's really making sure that we understood the needs, desires of our employees, which you can't do anything without really engaged employees helping support you. And then finally, executing on our strategy. And our strategy includes partnerships. And one of the important partnerships was with Geisel. And that there wasn't a great give and take relationship. And that was one of my top priorities, that you can't have a strong academic medical center without a strong medical school. They just do not exist without each other. And that we needed to invest in developing connections, relationships, shared goals with each other in order for us both to be successful. So, but thank you for asking. And I'm asking my team to give me a grade on that as we do our performance evaluations. So anyway, yeah, it's been a great first year. So anyway, well, thank you. So that concludes our Facebook Live. I want to thank everybody for participating. It'll be available streaming for all of you. And thank you again. And thank you, Duane.
Thank you for having me. I enjoyed this.
Yeah, my pleasure.